Thank you everyone for joining our weekly Fireside Chat. Today is Fireside Chat number 190. We have our speaker, Dr. Faiçal Jarraya, who will be taking us through the Declaration of Abidjan. What is it and why is it important? But before he starts, I would just like to take a few minutes to introduce him. So Prof. Jarraya graduated from the Faculty of Medicine in Sfax University in Tunisia in 1994. He earned his academic degrees from universities of Amiens in Paris and Lille. And he has got research masters from the University of Grenoble in France. Prof. Jarraya is a professor at the Faculty of Medicine Sfax and a nephrologist at the Sfax University Hospital. He is an European Society of Hypertension Certified Clinical Hypertension Specialist and a fellow of the Renal Association, European Renal Association. He coordinates the Professional Master of Hypertension organized by FMS and the continued medical education programs as the HT Academy. He is an elected ExCom member, and he currently acts as General Secretary of AFRAN and webmaster of its website and editor of the AFRAN quarterly newsletter. He's a member of the ISN-Africa board since 2016. He's a former General Secretary of the Tunisian Society of Nephrology, former board member of the Francophone Society of Nephrology, former member of the ISN Renal Sister Centers Committee and ERA EDTA Registry Committee. He is current member of the Scientific Committee of the SFHTA, French Society of Hypertension, ISN Dialysis Work Group, ISN Education Working Group, ESH Hypertension and Kidney Working Group, and SFNDT Committee on Humanitarian Nephrology Research. He is a member of several international societies, including ISN, SFNDT, SFHTA, ERA, ISH, and ESH. He has served as an ISN ambassador to the Republic of Congo. He chaired the scientific committee of the African Congress of Nephrology in 2017 and 2021, coordinated the ISN-AFRAN Abidjan Declaration on Prevention, Early Detection and Treatment of Kidney Diseases in Africa. Furthermore, he is a researcher, former head of research unit. He has been president of the Association of Development of Medical Research in Tunisia. He has been invited to give lectures in meetings of national, African, international societies, including ISA, ERA, ESH, ISHD, SFHTA, and AFRAN. He has co-authored more than 100 published papers, including 80 papers that are listed in PubMed, and 3 book chapters published by Laval University Press Canada and Springer. His main areas of interest include CKD, hypertension, diabetic nephropathy, primary hyperoxaluria, dialysis, and cardiovascular and renal prevention. So with that, Prof, I welcome you to start your webinar, and thank you very much for everyone that has joined in.
Thank you so much, dear Mazar, and thank you for the invitation and for the huge work you do with this Africa Healthcare Network. You asked me to discuss with you about the Abidjan Declaration. Why is it and why is it important? And thank you for that, because we don't speak a lot about this declaration, which is very important, I think, for our African nephrology. Thank you. So this is my conflict of interest. You understand that I give a lot of speech, so I have some conflict of interest. So as you see, first of all, when we try to look for this declaration, we have to start from the beginning. What is the situation of CKD in Africa from which we think about this Abidjan Declaration? We know that the life expectancy is increasing in the world, and especially in Africa, as you see here, it's exceeding nowadays the 70 years for the northern part and the 60 years for the sub-Saharan part. And when we look for the top 10 of mortality, leading causes of mortality in the world, you see here that we have non-communicable diseases, especially for the ischemic heart disease, which is number 1, followed by stroke. The situation is different when you see what's happening in Africa. The leading 10 causes of death in Africa in 2016, still the communicable diseases, I mean lower respiratory infections, HIV and diarrhea and so on. Also, we have a lot of problem of preterm birth and problem of asphyxia at birth, and this still very important in our countries in Africa. But what is important to note is that we have nowadays non-communicable diseases in the top 10, and starting by the ischemic heart disease, followed by the stroke. So it starts to be we start to have non-communicable diseases as a leading cause of death in Africa. So should health programs prioritize fights against communicable diseases in Africa only? And this is a question we have to discuss with international authorities. For example, the WHO. When we look for the WHO, and this is the 2008 data, and you see here we have the mortality rates according to the major causes. And when you look for Africa, we have the highest mortality, of course. But when we look, the number 1 still, as you see here, the communicable diseases, very important. That's true. But when you look for the non-communicable diseases, this part, and I just cut to make it on the same level. And you see that non-communicable diseases also is on the top in the world. We have the highest also non-communicable diseases death in Africa. And this is very important, but it is masked by the communicable diseases. Also, when you look at a dynamic view, if we can say like that, and you see for the communicable diseases, we have a reduction of communicable diseases as a cause of death in Africa. All is start to be reduced years by years from 2009 to 2019. However, when you look for non-communicable diseases, means ischemic heart disease and stroke, it's increasing. And this is very important that in Africa we have this exclusivity, which is the double epidemic. But a double epidemic with a regression in infectious, communicable diseases, and an increasing in non-communicable diseases. So if we don't do anything today, we will have a major problem in the future. In the second thing, let's have a dynamic view of the progression of health life expectancy in Africa. You see here that we have an increasing life expectancy in Africa. Nowadays, it is 64, the mean of life expectancy, in Africa. This is very interesting because we have combating the epidemics with the vaccination and so on. So because of that, we have an increase in life expectancy. But remember, when we have this age as life expectancy, remember that age is the first risk factor for non-communicable diseases. So in the future, because we have increasing already our life expectancy, we will face a huge number of non-communicable diseases. Are we prepared for that? I share with you the Tunisian experience in that field. And you see here in the comparing the Westerns and industrialized countries for the life expectancy, what's happened. For life expectancy in Tunisia, you see that it starts from 35, 40 years in the years 50s, 1950. You know that the freedom of Tunisia is 56. And starting on that date, you see that we have a huge increase in our life expectancy in a short period, only 50 years. And this is because in the, if I can say, up to the years 1980, as you see here, we have a lot of communicable diseases also. And we have a programs, you know, Tunisia working for health with Tunisian strategic health plan. And each years or many years, we have a new program just to combat some problems. And for communicable diseases, we have all these programs to fight against these communicable diseases. And starting for the 90s, and you see here 90s, life expectancy is 55, 54. And at that time, we have a lot of problem of non-communicable diseases coming. That's why, for example, in 1993, we have organized the hypertension diabetes program to fight this non-communicable disease and prevent, if I can say, the progression of these non-communicable diseases. And this is very important. When we are at 60, 65, it is important at this time, we shift from the communicable to the non-communicable diseases, and we have to work on the two, of course, but we have to start on the non-communicable diseases. And you see here today, Tunisia is 74 as life expectancy, with a little decrease regarding to the COVID, of course. It is important that when we look for the ranking of kidney disease as a cause of death across Africa, you see that for the chronic kidney disease, it is very variable, but it is on the top 5 in 7 countries, including, for example, Tunisia. I speak for Tunisia because it is my country. It is easy to speak of it. But also CKD is on the top 10 cause of death in 13 countries in Africa. So things are progressing now. And if you focus, for example, for the causes of death, you see that ischemic heart disease, when it is at the first, every time it is at the first or second level, CKD is on the top 5 or 10 of mortality. And this is very important. Look, for example, in Tunisia, the coronary heart disease is the first one. You see, after that, we find only non-communicable disease in the top 5. And in the fourth part, it is chronic kidney disease in Tunisia today. Look, for example, for Tanzania. For Tanzania, for example, the ischemic heart disease is in the 6th. So kidney disease is not on the first part. However, why it is not on the first part? Because, as you see here, communicable disease is still very important. In the third part, for example, you have HIV, for example. But it is very important to know that in Tanzania, I don't know the epidemiology there, but in Tanzania, we don't have a lot of diabetes, we don't have a lot of obesity. That's why we don't have a lot of ischemic heart disease, but you have a lot of hypertension, not well controlled. That's why, as you see here, you have stroke as the fourth cause of death in Tanzania. And this is very important to consider such data, for example, to predict what's happening in the future. We know, and you know, that chronic kidney disease is today at the 16th, ranked 16 in years, in the cause of death, years of life lost. But you know that it will be on the 5th, in the 5th part as a leading cause in 2014. And for that, the World Health Organization classify cardiovascular disease, diabetes, cancer, and chronic respiratory disease, but do not consider chronic kidney disease. And this is very important, and you understand why the International Society have this action to have our signature to make kidney health and kidney disease as a major non-communicable disease. And it will be not the big 4, but the big 5, if I can say, NCDs that the WHO will plan. When we look for the causes of kidney disease in Africa, we know that mostly we have the diabetes mellitus, hypertension, and glomerulonephritis, especially induced by infectious diseases. And if diabetes kidney disease is top 1 in north of Africa, followed by hypertension, this situation is a little bit different in sub-Saharan Africa, where the hypertension is, as you see here, an example of study done in Abidjan. And hypertension is the #1 cause of end-stage renal failure or renal failure, and HIVAN is the second one, and diabetes is then the third, fourth one. But what is important comparing to the Western countries, that renal failure and end-stage renal disease is coming at an early age, 52, 36, which, however, for example, here in France, we start dialysis at 70 years, means is 70, 75. So we start early dialysis, means that we have people at working phase of age, of their age and will stop to work because of end-stage renal disease. Look, for example, for the causes of end-stage renal disease. We say that hypertension is the most one. For example, looking for this famous study from Anastasia Djoutier from Cameroon, which is a very interesting one. Here we have a program of HIV. We treat HIV patients, about 10,000. From these patients, 55% have hypertension. They are followed at the hospital or unit for medical units. 25% with hypertension, only 1% treated. For 25 patients from 2,460 patients. And from these patients, all are treated for HIV. And from these, only 5 patients, 5 from 2,400 patients who are controlled. This is very important to consider that these people are followed. Looking for people who are not followed, and this is very important. That's why we have a lot of things coming nowadays regarding to hypertension, and especially hypertension in Africa, which is today, as it is described, a big catastrophe. High blood pressure is one of the leading causes of premature death in Africa, and its prevalence, which can reach 54% among adults in Africa, is one of the highest rates in the world. And even more worrying, only 7% of hypertension have their blood pressure controlled. And in Africa, the estimated number of people with hypertension has steadily increased over the past 3 decades and is expected to reach 216 million people by 2030. Why? That's why it is a real catastrophe. That's why the hypertension, the World Hypertension League today is working, especially with my colleague Gianfranco Paratti, working to increase knowledge of hypertension and have an action regarding to against hypertension. Nowadays, 7%. What it is planned is to get to 51% in 2030 with this 80% rules. Means 80% are aware of hypertension, 80% treated, and 80% controlled from treated patients. The second one is HIV. Regarding to hypertension is increasing, HIV is decreasing, and we are not at the 75 target of a reduction of HIV in Africa, but we have about a 40% reduction between 2010 and 2020 regarding to the incidence of HIV. So we are expecting a reduction of HIV as a cause of end-stage renal disease or end-stage renal failure. But we will have an increasing in renal failure because of hypertension, because of cardiovascular disease induced by hypertension, but induced also by cardiovascular disease induced by hypertension itself. The third one, the problem is diabetes. Nowadays, this is not a major problem in Africa. Only 4.5% in 2021 who have diabetes in Africa. It will increasing to 5.2 in 2045. But the problem is 55% were undiagnosed, and this is the highest proportion in the world. And the other problem is that diabetes should be integrated into existing primary healthcare services to cover its diagnosis and lengthy and costly treatment, and this is very important. So we have to work on this to avoid the development of diabetes by early detection, but also lifestyle action. So when we look for the overall prevalence of CKD in Africa, we find that it is increasing. We have the data done by ISN, given by ISN, but I usually prefer this data done by African for African, and the data by Kazé telling us that the proportion of the prevalence of CKD in Africa is 6.8, but the lowest is in the north, 6.1, and there where there is the least workforce shortage, you remember, and the highest in the Western Africa, 19.8%. Looking for what's happening in the world, it is very important. We don't have really today a very strong epidemiological data, but this is very important to consider these data, which I think it's very important to promote programs to prevent hypertension, kidney disease in Africa. So what about CKD prevention programs existing nowadays in Africa? When we have been together with the kidney guru discussing how to involve with the fighting kidney disease in the world, and especially in low and middle income countries. And when we look for the increasing of CKD epidemic, also we can develop dialysis, we can develop transplantation. This is very interesting, but the problem is all these are unaffordable, and we need a lot of techniques that we don't have it today in Africa. What it is maybe possible to do is an early detection and prevention. This is very easy, and this is also saving for money. And when Sarala said in 2010 that Prof. Naker said that Africa and nephrology is the forgotten continent, it is not today, about 15 years after the forgotten continent, but it is still the forgotten continent of kidney prevention. See here what's happened, what the programs we have. This is only the programs I find it in the internet published regarding to the CKD programs. It is only for a checkup, if I can say. It is not an interventional program. Also, when we see what's happened, for example, with the International Federation of Kidney Foundation, and you see here what's happened in the world and what's happened for Africa, we have only 3 countries: Egypt, nothing; Nigeria, nothing. We have programs only in South Africa. The problem in Africa that we don't speak a lot about kidney disease. So the people who come in our office come with a GFR very low. This is the data from Cameroon, from my colleague Marie-Patrice Hall. And as you see here, they come with GFR between 25 to 30. We don't have a lot of things to do, just to be with them. And we see that it progresses to the renal failure. And the problem is that CKD patients in Africa are referred late to nephrologists with advanced CKD. When you look, for example, what's happened elsewhere with a low-income country as Nepal, for example. In Nepal, about a population study, 20,000 people checked for hypertension, high fasting glycemia, proteinuria, and renal failure. That's it. They collect 4,000 cases, and they follow them for 3 years. And it is very interesting here that we see that they give them a prescription of antihypertensive, antidiabetic, and low-cost nephroprotective medications. That's it. Initial proteinuria checked by dipstick, there is a normalization of 63% of cases, and also in 3 years. And initial mild to moderate renal impairment, you see here that the kidney function has stabilized or even improved. We are in a low resource setting, and it is very effective as a program. So in Africa, we have the program done by our colleague from South Africa, which is especially the chronic kidney disease in Africa, CKD Africa. But as you see here, it is especially for collecting data. It is an epidemiological study, not an interventional study. So it is interesting as a study, but we don't prevent. We have also the Africa Health Care Network. I find this in the internet, but I don't find some publication regarding what happened for prevention. They check. It is already seen here more than 3,000, but what they do to prevent and what the result of prevention, I don't find. Maybe Dr. Amirali can tell us more about this. And also the third one, which is very important also, is the IRN, Africa Research Network, who has suggested the DACA call for not only nephrology, but for all the NCDs. And by this action, the kidney disease is included in this program, and we have the report, and we are working with the international United Nations to fight CKD and not only CKD but NCDs in Africa. So prevention, we don't have a lot of things. However, prevention is very crucial in Africa. I try to tell you why in 5 minutes. You see here that detection of kidney disease is one of the easiest. If you detect coronary artery disease, you have to have ECG and so on. For kidney disease, it is very easy. You have just to check blood pressure, urine with albuminuria dipstick, that can be sufficient, and you measure the creatinine. So the diagnosis is very, very easy to do everywhere in our continent. But if you do nothing, you know, this is the evolution. These, for example, the type 1 diabetes mellitus with diabetic nephropathy, and you see if we do nothing, and people are on dialysis in 7 years. That's why from this data, we developed not treating kidney disease, but the concept of delaying end-stage renal disease, what we call today renal failure. And the first thing to do is hypertension, because treating hypertension, if here you see patients with diabetes mellitus, with diabetic nephropathy, and we treat hypertension, we reduce decline of GFR, and we reduce by this way, by the same way, the proteinuria. So it is very interesting when we start treating hypertension, even if you use metoprolol, hydralazine, furosemide, thiazide, which is not the drug we use today for hypertension, we delay renal failure 15 years. And it is very important to consider this. Also, we have the RAS blockers, and with the RAS blockers since the 90s, we know that this medication will reduce the doubling of creatinine and death dialysis and need for transplantation for these type 1 diabetes mellitus, even if their blood pressure was normal when we introduced them in the study. So we have the first medication to prevent kidney disease. At the same time, this medication reduces blood pressure. And as you see here, for example, in the STENO trial, that at 20 years, the death or the GFR less than 45 milliliter per minute, we have again, as you see here, 44% reduction of progression of kidney disease or death. Just treating patients with ACE inhibitors with also a blood pressure less than 130, and treating also diabetes and dyslipidemia. And this is very important. However, you see that we have a huge residual risk that persists. And also we have an escape for proteinuria who will increase after that. And you see here, this is a follow-up of 20 years of type 2 diabetes mellitus, included just because they have only microalbuminuria, A2 albuminuria, without any other problems. So regarding to what's done with cardiology, what's done with diabetes, all are reducing mortality. However, for nephrologists, we don't have a reduction really. It is not very significant. However, in the 2020s, we start to have medication to do this. And of course, the SGLT2 are the first medications, dapagliflozin, that reduce not only kidney disease progression, 39%, even diabetes or non-diabetes, but also they reduce at the same time, the same study, cardiovascular endpoint and mortality, 30% each. Which is very important. This is the first time we declare this. And that's why we have our papers from AFRAN that we say that with this medication, it is very important to introduce it in Africa, because as you see here, we can delay more than 50 years renal failure from end-stage renal disease from patients treated. And these are diabetic patients. When you see from the impact kidney disease trial, this is very interesting because we have also non-diabetic kidney disease, and you see here that if we start this medication early at early degree of kidney disease, we can delay up to 26 years the start of dialysis. However, when we start at 20 milliliter per minute, the gain is only 2 years. And it is very interesting because most of our patients, we see them at about 50 milliliter per minute. about 50 milliliter per minute. We start these medications, and you see here, this is the AMPA, we start it, and we see that we will delay the start of dialysis about 15 years. 15 years. It is very, very saving for money. And we will prevent, we will not do 2,200 dialysis sessions for this patient. You can look how many we can save money for our community. And in 2021, of course, we have this finerenone, which is add something else with the reductions with about, as you see, 18%. At the same time, they reduce mortality. This is very interesting. And when we combine SGLT2 inhibitors with finerenone, we have a reduction not only on the functional parameters, but also, as you see here, when we combine them at the low dose, it is very effective in reducing the, as you see here, the cardiac fibrosis score and the kidney fibrosis score, and these are done in rats, of course. But you see here, these are antifibrotic agents that they can prevent the degradation of kidney and heart and prevent degradation of kidney and heart. And finally, this of course, flow trial. At the same time, they reduce progression of kidney disease. These are diabetic patients. They reduce kidney outcome by about, as you see here, 24%, very significant. And it is at the same time, and this is the third molecule that at the same study reducing kidney outcomes, but also, as you see here, heart disease outcomes, which is very important because it is important to save heart and kidney at the same time. So, as you see here, it is important to start to promote prevention, but there is a lot of barrier to overcome prevention in Africa. The first barrier is the health strategy. Our health strategy is based on combating and being against communicable diseases. We have to work on these, if I can say, programs to introduce them non-communicable diseases. And the example of HIV in Cameroon, I told you, is very important because we treat HIV and it is much more easy, much more cheaper to treat hypertension, and we don't do it. And this is not possible, if I can say. So we have to move our strategy from communicable to non-communicable disease. And so we need to adapt our community disease health strategy to integrating non-communicable. The second thing is regarding to the drug supply, which is a very, very important problem. The Africa Research Network done the study in Africa, and they find that for treatment for hypertension in Africa, for example, for the amlodipine, we have a lot of poor quality amlodipine, a poor quality captopril, and a poor quality for generic medications. And for example, it is a copy of amlodipine. People buy amlodipine, it's not amlodipine, there is nothing there. And the drugs are mostly produced in Asia, 50% of those sold in the street market. And these drugs produced in Asia, 35% were from with a poor quality. We can't progress with this medication. I show here the example of Tunisia. When people have to introduce medication in Tunisia, they have to ask the Department of Pharmacy and Medication to introduce this medication. We should have the authorization before do it. We can't do it by ourselves. We have to get to this department, and then you have to check the security control because there are a laboratory for that. And then there is only one organism, which is the central pharmacy, who is allowed to buy medication. and for this way, by this way, we don't have copy, we don't have false medication in Tunisia. It is very important to consider our way to commercialize medication in our countries. The second thing is regarding to the health budget barrier. As you see here, the health budget barrier is decreasing. It should increase, but it is decreasing. And the problem, I think, because you don't have a collective purchase, as you see here, Western Africa to buy hemodialysis and peritoneal dialysis devices pay the same thing, much more than what we do in Northern Africa. So I think that it is very important that we have a centralized purchasing of essential drugs that we can reduce, of course, the cost of drugs. And also we should develop the universal health coverage as it is done already in Northern Africa, for example. And it is very important that people will pay this insurance that this insurance can, of course, refund people who buy medication. Finally, also for the health budget barrier, it is very important that when we look as a doctors for patients, we are here. However, the policymaker look at this level means that he look for all the people, all the society, and all the money they have, and the macroeconomic is very important when we define the diseases. We try to apply guidelines given by European society, international society, and so on. However, when we apply this, for example, for blood pressure, it is important to translate it in Africa, because when we look for the American, for example, definition of hypertension, means that we have to treat all our patients, for example, in Tunisia, which is not possible. 40% of the population should be treated. However, when we look for the blood pressure more than 160/95, when we start our hypertension program, this definition was made. And at that time, we have only 14% to treat. And 14% is not very expensive for the population. So we have the agreement of the health authorities to treat hypertension for all people in our country. And this is very important when we go to the Ministry of Health, that we should have some definition that we can reach for it with the treatment. For example, when we go for the hypertension, we look for sprint, that's why 130, but what sprint is for cardiovascular disease patients, elderly patients, and CKD patients. When we look for, and this is the Cochrane, when we look for people with mild hypertension and low risk population, we don't need to start treating them at 130. We can start at 160, because when we treat them between 140 to 160, we don't have a significant reduction in any of the cardiovascular mortality, coronary heart disease, and stroke. All are not significant. So when we go for all the population, yes, we have to define hypertension as 160/95. And for people with CKD, with cardiovascular disease, we have to define the hypertension 140/80 or 90. So we have to adapt these international guidelines, because we don't have the same funds, health funds, as the Western countries. And finally, the problem is the workforce barrier. And you see here the workforce barrier, because all, I don't develop more, but you see here in this publication that the percentage of workforce is about 25 to 28 coming from low and middle income countries in United States, United Kingdom, and so on. And you know this publication from IKE showing that it is very reduced in Africa, the nephrologist. 0.62 per million population, comparing to 995 in the world. So we have to encourage the medical career and improve working condition, and try to keep doctors in the country, but also we have to encourage the delegation task to nurses and health workers to help us. because we are not very important community. And finally, of course, we have to increase awareness. And I think that World Kidney Day is a very fantastic moment, but it should be every day a World Kidney Day. Look for what's happening in Tunisia. You know what we did? Looking for the results. We participate to the heredity registry, as you see here, and we treat all people needing dialysis. So we don't have people who need dialysis and we don't treat it. And the Sfax, where I come from, is participating to this registry. And you see here, Sfax, for example, we have one of the highest incidence regarding to the European countries, one of the highest. Of course, we have one of the highest of the prevalence, but at the same time, we don't do a lot of transplantation. It's increasing these years. We are doubling this by 5, 6, 10 times, but it's still very low regarding to the incidence. We have 375 per million population as an incidence. So getting back to the kidney prevention, I think this is very important to consider. If you don't have to have these figures in your countries, it is important to have an early diagnosis and an early treatment of CKD at an early stage. This is what's happened in Africa, in sub-Saharan Africa. And you see here most of population where if they are treated one or less than one session per week. And you know, this is not saving for our population, just we are delaying the death for our population with CKD. So the dialysis for all is not the solution. As you see here, for example, in Kenya, if we have to treat all population, 8 to 15% of the government health expenditure should be done for this number of, for this population, only this CKD population with end-stage renal failure. Affordability, sustainability, you understand the response. And if we try to just look for a dialysis session cost is $72 in Kenya. So for a month, we have $864 US. If we try to, with this amount of money, we look for how many people we will treat them for hypertension, 288 patients. We treat them for hypertension, they will not develop CKD. And we will treat 86 patients with hypertension and diabetes mellitus. We will not have development of end-stage renal failure. This is very important to consider with our community. That's why this this Abidjan declaration was made. It is for CKD prevention, detection, early detection and treatment of hypertension, of kidney disease in Africa, and we should act now. And this is very important. This is the people who are who work on this African Abidjan declaration. We were with the ISN and with the CMA, Commonwealth Medical, and what we say that we noted when we have our meeting that we have the high burden of kidney disease, the relentless of progression of kidney disease, but also the increasing morbidity and mortality due to the kidney disease, the low health budget we have in Africa, and the high cost of kidney replacement therapy regarding health budget in Africa. And because of this, the International Society of Nephrology and the African Association of Nephrology try to help, if I can say, ask to help develop a roadmap to address common causes of kidney disease and raise awareness and knowledge about these silent diseases and their risk factors, and develop programs to delay the development and progression of kidney disease, not only checking, to delay the development and progression of chronic kidney disease with a global action on renal, cardiovascular, and metabolic common risk factors. And this is very important because we did it in 2021. In 2023, the American Heart Association published the first paper on the renal kidney, on the CKM cardiovascular, kidney, and metabolic syndrome. And you see, we work on the same thing, but we started before. And others costs of diagnostics, pharmaceuticals, dialysis materials, and fluid, and accessibility and affordability for low income and low middle income countries, and organize the circuit of drugs, as I show you, which is very important. Help and train the general practitioners, healthcare workers, and community care workers to help address the burden of the disease, and then finally address ways to engage the governments, the African Union, European Union, United Nations, and the World Health, to understand the importance of kidney disease and its risk factors as a part of achieving universal health coverage. And we addressed this algorithm just for how to do, just to raise the awareness on renal, cardiovascular, and metabolic risk factors with the population booklet messages by TV, cell phone, by football stars, single stars, and so on. Health workers, nurses, we should to raise awareness on health workers, nurses, GPs, and also specialists regarding to the kidney disease and what we have, the need to check the kidney disease. Also, we have to move for the detection, prevention, and lifestyle promotion, and this is by task delegations to nurses and under the GP's validation, and we have devices that we can use them without need for laboratory and so on, only by sticks, sorry. So it is very easy to have, to diagnose kidney disease, if I can say, to diagnose diabetes, and so on, and to diagnose hypertension. And then the treatment, the early start of treatment with the treatment algorithm by GPs, indications, nurses follow up if we don't have a lot of doctors, with a generic cheap poly pill for hypertension and even others, a generic cheap poly pill for cardiovascular prevention, so with statin and aspirin, and a generic cheap poly pill for anti-diabetic medication, oral anti-diabetic medications. And only people with complication will go to the specialists. And so with such a program, we can go ahead and prevent such a catastrophe that we can have in the future. So we have to work together, not only as nephrologists, we have to overcome these barriers, and we have to work together. We have to work with all the others just for the primordial prevention, primary prevention, and our task will be especially for people with advanced kidney disease and, of course, treating people with renal failure. And this is the task, and we have to move on with this declaration just to have funds and to work with the national societies just to implement this Abidjan declaration in their countries, of course, and working with health authority, as you see. Please do not forget that our coming Congress is in many days from now. It is on the 14th to 18th April in Tunis. So welcome to you, and you can check for our websites and be a member of AFRAN. It's very important, of course, and we will come to this big family to work together to develop nephrology in Africa. Thank you so much for your attention.
Thank you very much, Prof, for your insightful presentation and the build-up towards the need of the Abidjan Declaration. I believe that this is something that should be applied holistically throughout the continent to try and reduce, if not, slow down the epidemic that is looming over our heads. So thank you very much for that. We have got a few comments on the chat box. I'm just going to read through. So Bilais says, I think that, during the talk, he mentioned that hence more efforts and budget should be invested in primary care, where hypertension is diagnosed and treated before complications arise. And then,
yeah, this is very important. We have to work with primary care to prevent kidney disease, but which is important is that when we work with primary care, we will not prevent kidney disease only, we will prevent also cardiovascular disease, we will also prevent diabetes. So it is very important to start in primary care. And as you see, the risk factors are common for even metabolic diseases, kidney diseases, and cardiovascular diseases.
Thank you, Prof. The other question from Dennis, it's asking what efforts are being put in place to increase kidney transplant for the sick patients in resource-constrained countries?
Yeah, it is very important that this have to come, I think, after that. We have to work together, I mean, with development of transplantation, with development of dialysis, but we don't forget that we can't treat all people with transplantation and dialysis, and the most saving thing is starting by prevention. That's why we go for the prevention as the first thing to do in Africa today is for non-communicable diseases, and especially for CKD, of course. For transplantation, we have a program, of course, with AFRAN, and in Mauritania it will be in mid-May, a very important forum for how to develop kidney transplantation in Africa, shared by our colleagues from the executive committee, Professor Sidi Ali, who will develop this, and we will find this in our website. I can share it with you, but if you go to www.afran.com, we will find it in the main page, this important manifestation also, and this try to develop something if I can say, to develop transplantation in Africa, but also we have an important work done by the transplantation committee of the AFRAN, who work a lot to develop the transplantation in Africa.
I think there's a comment on treating hypertension for those patients who have got low risk at higher levels of blood pressure. So they say the challenge with delaying treatment under 160 until 160/95 in poorly seeking is in the poor seeking behavior in our African populations. The patients who today is at 150/90 might come back with complications.
I can have a comment on that. This is very important because we discussed this many times with the European Society of Hypertension in many meetings, because I belong from this working group dealing with hypertension, especially in Africa. And what is important to note is what we can do. If you treat all the population, you can treat all the population at 140 or 150. We don't have money for that. So if you treat all people who have 160 and over blood pressure, you will decrease the risk of complications. When you treat people from 140 to 160, we will reduce, of course, complication, but we will not reduce it a lot. It is you pay a lot of money for many short benefits. So if you have some money, you don't have a lot of money. If you have a lot of money, you treat everyone, of course. But you have a lot of money, you treat everyone with 160 and over for blood pressure. This is very beneficial. And for people with CKD or cardiovascular disease, we treat them 140 and over. It's not a problem for that. So we can treat everyone. The message we have is you don't have to treat only people living, I don't know, people living in Dar es Salaam, that's it. You have to treat all people in all Tanzania to reduce the complications. So if you treat all people with 160 and over, we don't have a lot of persons to treat, if considering 160 and over. All people are treated with a very cheap medication. The benefits is very, very important in the coming years. Otherwise, if you treat only some population because they have money, because they can buy medications, okay, you will save them, but all the others will have dialysis, as you see here, stroke, and so on. So what strategy you have to do?
Yeah, and that is the case in most developing countries, including Tanzania. People who have got access to insurance will be able to access medical care, but those patients who have low socioeconomic status do not even have the money to go and see a doctor. So completely agree with you, Prof, in that way. But I think I feel also the non-pharmacological treatment for these illnesses is also fairly important to advocate, which will also help in reducing, the risk factors and complications later on. Prof. Bima, your hand is up. You can speak.
Prof. Jarraya, thank you very much for the very insightful talk. I hope you can hear me. I'm a pediatrician, so obviously my focus is slightly on pediatrics, but I just want to bring to your attention that we did a study for hypertension, and we did it in grade 12 pupils, and we found that in grade 12 pupils who otherwise were perfectly normal, they had already hypertension 14% in schools. And the thing was that obesity was the most important correlation with hypertension. So I agree with what was said by the previous speaker that lifestyle changes are very, very important, because we looked at the diet of these patients. Previously, hypertension was very rare in our indigenous Black population. But now, with the change in economy, the change in political situation, etc., everyone is eating takeouts, everyone is eating all junk food, you know what I mean? And high salt, high fat. So that should be also something that we should focus on, besides just, drug therapy.
Thank you, Dr. Bima. Yeah. And how are you? It is very important, of course, that you note. It is very important to work on lifestyle. This is very important. And this is on the full program of cardiovascular and kidney disease and metabolic prevention. That's why I said to you, in our program, when we put our idea to work, it is not only to save kidney disease. We don't want to only to work on kidney disease. We have to work on all risk factors for kidney disease, including, of course, obesity. And in Tunisia, for example, this is catastrophic nowadays because of the obesity in people on school, in child on school and so on. And we have a lot of increase of cardiovascular. We have nowadays also a problem of heart attack at 25 years. Very important. You consider these people start smoking at the age of 10.
So whatever happens, try to tracks into adulthood. So, thank you.
Thank you, Prof. It's similar again in Tanzania as well. We've got younger and younger people who are becoming hypertensive, diabetic. The amount of obesity that is there is steadily growing, especially in the urban areas. And majority of our patients are hypertensive, are diabetic. And there is this other idea of using, herbal medication for treatment of these illnesses, of metabolic illnesses. And, this plays a very big role, in majority of our patients. So they go untreated for a while, and then they are in denial. And then they feel like pharmacological management makes everything worse. And then they go to herbal medication, which technically accelerates everything. And then they come back when it's too late. And now you have to scamper around and try and see what you can save. So I think holistically, awareness is very important. And I completely agree with you. The World Kidney Day should not be on a single day. It should actually be every day in our clinics when we see patients, especially patients at fairly early stages. And those patients who have got cardiometabolic, risk factors should actually be counseled much earlier, before they even start having albuminuria and all of these things. Only then will we be able to achieve our targets, I believe. Okay. There is another question by Dr. Huda Akrabi, who is a nephrologist in the northern part of Tanzania. She says, did the commitments outlined in the Declaration of Abidjan put any policies and practices around kidney health in Africa, focusing on regional collaboration, resource allocation, and the adoption of preventative measures for CKD?
Yeah. It is very important. Yeah. The problem that we don't go ahead with this declaration. We tried first when we put it at the first time. When we make it at the first time, we try to go ahead with the WHO, for example, and look with to have meeting with the World Health Organization just to raise awareness regarding to what's happening in Africa regarding to the NCDs, and especially for CKD, because we are not able to treat our patients with dialysis and transplantations. And it is not working as we think to do with the World Health Organization. But I think that for the coming years, I think that, and Prof. Abdu is already with us today, we think that it is very important that we work with the national societies just to adopt this declaration in their country one by one. And I think that this is an important task for him as a coming president of AFRAN to work with the national societies just to adopt this declaration, everyone in its country. And I think that if we work one by one in his country with health authorities, of course, we can go ahead with this declaration.
Thank you, Prof. One more question. Duke says, can you kindly talk to us about the use of renal syrup even after starting dialysis? So maybe if I can just add on top of that, Renochlor is a medication made of I think is a chlorophyll or something. It's some sort of medication that is been marketed as a drug that reduces progression of kidney disease. So it is in the same line as the alpha ketone analogs and the probiotics. So this is something that is in the similar lines to that. So perhaps your opinion on that, Prof?
I don't know this medication, sorry, so I can't advise, but what I know is regarding to the Arabic gum, for example, at certain time they said that, oh, that's perfect, that delay, the progression is not delaying, it's just reducing, if I can say, urea, but it's not delaying the progression of CKD. So when you get with, renal failure is not only urea, renal failure is especially the toxins that accumulate in our body, and this is very important. And you know that if you have a GFR less than 10, you have an increase of this because it is exponential. We have a huge increase of these toxins in our body, and that's why we have to start dialysis, because it is not only urea, it is especially because of these toxins. We know we have some patients that we treat on dialysis with 6 millimole per liter for urea, but the problem is that they are in dialysis because they have this renal insufficiency. And when you see this population, especially there are people who are not eating a lot of proteins, but not eating proteins is not very beneficial for the health. We don't have only kidneys to fight, So I don't think that this medication is very important. We don't read it in the international publications, so I don't think that it have a huge impact. Otherwise, of course, we know it, and we will have a lot of publication on this.
Thank you, Prof. I don't see any other questions in the chat or in the Q&A. Perhaps if our panelists have any questions, Prof. Niang.
Yes, just a contribution. First of all, to thank Professor Jarraya for his nice presentation and the great job AFRAN is doing on the kidney prevention and awareness of population and also health authorities. And I would like also to emphasize on the point of care of testing creatinine. And I would like Faiçal to emphasize on that point, because it's very, very important to diagnose CKD in the early stages. And that's why I think in the future, in our strategy, we will have to put on strategy using point of care testing like creatinine or albuminuria for early diagnosis. Thank you very much for the nice presentation and the organization of this webinar.
Thank you, Prof. It's very important that what you said, and this is on the slides of what we should do. And as you see, there is the devices, and all these devices are point of care, of course. And it is very important today that we have validated tools to check creatinine just with a drop of blood. And we can do it everywhere, even the desert or far from any laboratory, and we can have the diagnosis of chronic kidney disease. That's why I think that we should develop these tools in our country, in our countries, in our continent. And the problem today, it is because it is very expensive. The strip is about $10 or $8, something like that, only the strip. So it is a little bit expensive, and we should have if I can say, a purchase for most Africa with a small price. We should have something like that, we can have it an affordable price, that we can have it in all our countries. The second thing, I think it's very important, the hypertension. I guess that this is the leading cause of CKD in Africa, and it is very impactful for Black population, hypertension. You know, I am in many organisms that working on hypertension in Africa, in Black population, and I can if you want to present a talk regarding to hypertension in Black population, that I can do it, of course. It will be amazing, but it is very important that hypertension should be combated. We should have action against hypertension, because the leading cause of CKD, the leading cause of stroke, and it is very important that if you have these two diseases, it is a great problem for our population. So that's why I think it is very easy to diagnose hypertension. It is very easy also to treat hypertension. We don't need the doctors to treat hypertension, if I can say. So we can, with the task delegation, we can treat hypertension in all our countries. And this is very important if we want to prevent development of CKD, stroke, cardiovascular disease, and so on.
Thank you. Thank you very much, Prof. Dr. Lloyd, do you have a comment or a question?
Thank you very much, Professor Jarraya. So it was a wonderful presentation, and very important aspects, including the non-communicable diseases, kidney health, the fifth leading cause. ESRD comes earlier, diabetes or hypertension, depending on the region. The importance of HIV, early treatment, blood pressure control, DM integrated into CKD care. Africa, globally forgotten. Life expectancy in Africa is increasing in a short period of 50 years. I mean, it's beautiful. Nephrologist numbers are low, but we need to increase awareness and, of course, ultimately the declaration. Thank you very much for the wonderful presentation. So we've been trying from our side to actually do something. Since now we have about 50 operational centers across East Africa, and probably will be more as with time to go. We have actually, it is a process. In each of these centers, we have actually restricted our activity, prevention activity into these centers. We initially started just to see how the process can be put in place. And so we started off with Excel sheets, training the people at each of these centers. And of course, the process in each center is different. Sometimes it is a GP who looks after, sometimes it is a resident doctor who runs the clinic, sometimes it is a physician, sometimes it's a nephrologist, sometimes the center physicians within the hospital treat, and sometimes it's a visiting nephrologist who treats. So this is a big challenge we have. You see there are 50 centers, but what we're trying to do is uniformly try to capture patients who come to the center. That is number one. So we have actually now put up an application, made an application, which is cloud-based, and which can actually, all the data can be entered in, including the creatinine. Now the problem is standardization of creatinine, as you rightly mentioned. It has been a problem. So what we are doing right now, we are just going to start a study to actually use point-of-care creatinine testing with a device called Novostat. which is actually used in Cameroon, from Cameroon actually, and that's something we are now going to start. We are just working on the protocol and getting the ethical approvals now as the first step. So 3 centers now, however, are already now, we have started 3, one in Kigali, one in Gisenyi, that's in Rwanda, one in Moshi, that's in Tanzania, and now 2 in Nairobi that are just starting now. We have actually done about 2 months of work and on the application collecting data. So once you put in a creatinine, we automatically get the EGFR. And then we actually advise them based on the stage, what is the management, uniform management to be done. Of course, there's a lot of work still to be done, training of doctors, making drugs available, as you rightly pointed out, control of hypertension, nutritionists. We have got nutritionists across the board who, advise on salt restriction, other dietary issues that come up. So one is capture early kidney disease, but not only early kidney disease, but we also focus on capturing the later, the late creatinine, the low GFR people, so they don't progress to complications of kidney failure and go into early dialysis. So it's a 2-pronged approach that we are trying now. It has been slow, but I think something is happening, and we hope in about 1 or 2 years we should have something really good to show across the country. I mean, across these 3 countries and centers. So it's a slow process, but I'm sure it will get organized and come in place. Yeah, thank you so much. Wonderful. Thank you so much for your talk, sir.
Thank you very much, Dr. Lloyd. I believe we have come to the end of our presentation. Prof, it was lovely to have you on board. It was a great and insightful presentation. It was a very engaging presentation. As you can see, I believe that prevention is very close to all of our hearts. And I think this is something that is recorded for future viewing for the members that may have not been part of this webinar. So on behalf of Africa Healthcare Network, the Fireside team, I thank you very much for coming through, and we hope to have you again soon. Thank you.
Thank you so much. Thank you so much for the invitation. Thank you so much, and bye-bye.
Thank you. Thank you.
Thank you, Professor Niang. Thank you very much for coming on as well.